Hi, good afternoon. Thank you for joining us today. My name is Lori Smetanka, and I'm the Executive Director of the National Consumer Voice for Quality Long-Term Care. I'd like to welcome you to our webinar series, COVID-19, Advocating for Nursing Home Residents, sponsored by the Consumer Voice, the Center for Medicare Advocacy, Justice and Aging, and the Long-Term Care Community Coalition. This is the fifth in our series that we've been doing on this issue. As you know, there have been many developments that have been happening very quickly with respect to the COVID-19 crisis in long-term care facilities. And so we have been holding these weekly programs in order to keep you updated on the latest information, guidance, and actions that have been coming down at the state and federal levels. Next slide, please, Libby. On our agenda today, we're going to be talking about the newly released recommendations from CMS on the reopening of nursing homes, which, as you know, have been under very severe restrictions on who is permitted to enter the facility. We know that the inability of family to visit their loved ones has been very traumatic for both the families and the residents, and so careful planning and consideration need to be given to how we can lessen those restrictions in a way that makes sense. So we'll hear about the recommendations that CMS is providing, and we'll also be sharing some tips and strategies that you can use in your own state to advocate for criteria that will both protect residents but allow opportunities for limited visitation in these facilities. We're also going to be hearing about a new General Accountability Office report, GAO report, that was released the other day on infection control deficiencies in nursing homes. It is very directly related to what's happening now during the pandemic, so we'll be interested to hear about that. And then you'll recall a couple weeks ago we talked about the new reporting requirements that nursing homes have to meet. So now that they have gone into effect and nursing homes are required to report data both to CDC and also to residents and families, we thought it would be useful to highlight again what information they have to share with residents and families and what's going to be publicly reported. And then again, at the end, we'll use whatever balance of time we have left for discussion and questions. Next slide, please, Libby. Our speakers today include Eric Carlson, Directing Attorney with Justice and Aging, Robin Grant, from the Director of Public Policy and Advocacy at the Consumer Voice, Toby Edelman from the Senior Policy Attorney with the Center for Medicare Advocacy, and Richard Mollett, Executive Director of the Long-Term Care Community Coalition. Next slide, please. Just a reminder that today's webinar is being recorded. The recording and the slides will be emailed out to all of you next week and will be posted on the Consumer Voice website. You can also find the recordings and slides from the previous webinars on the website as well. We will be putting a link to today's slides in the chat box where you can download them. As a reminder, please put your questions in the Q&A box on your control panel that you'd like considered and asked of the presenters today, and use the chat feature to make comments or discuss points among yourselves. So again, we'll get to questions, as many as we can, at the end of the conversation today. So with that, I'm going to turn it over to Eric, who's going to start and lead us through an overview of the new reopening recommendations. Eric?
Thanks very much, Lori. Let's move on to the next slide, please. As Lori mentioned, these are recommendations, and CMS in the document itself and his discussions has made it clear that that's the case. As I'm sure we're all aware, the federal government has given states a lot of discretion, and then in turn, depending on what state you're in, the states give a fair amount of discretion to counties, for example, to determine exactly how they want to move into reopening the area after the lockdowns that have occurred across the country. So these are recommendations from CMS. That's how they're styled. It's up to the state to choose the exact procedure, and there may be some variance within the state, particularly the obvious distinction between urban areas and more rural areas. If you see the slide here, the two items listed there are the relevant documents if you want to take a look at them yourself. Move on to the next slide, please. These are the factors to consider, and you'll see in a couple minutes I'll walk through phase 1, phase 2, and phase 3, and these considerations come up. over and over again, a lot of them are just continuous requirements that the facility has to be able to meet. I'll just flag here in the middle the discussion of adequate testing. That's obviously been a big topic in society generally and also in nursing facilities. And the recommendations from CMS speak to testing residents as a baseline matter, and then testing again if there's a record of an infection being transmitted within the facility, and then weekly testing thereafter until there's a finding that none of the residents are testing positive. And with the staff, relatively similarly, but more rigorous, a baseline test and then weekly tests of staff to ensure that none of those have picked up an infection. Next slide, please. These are tied to the broader federal regulations. They're called Opening Up America Again. Like those broader federal regulations, the nursing facility recommendations are in 3 phases. The recommendations note that because nursing facility residents are more vulnerable, and because, as we all know, there have been such horrific outbreaks in nursing facilities, that nursing facilities are going to reopen more slowly than the rest of the country. The recommendations speak of a 14-day lag behind the local community. If the community moves on to phase 2, let's say, that the nursing facilities in that community are going to be at least a couple of weeks behind that as far as transitioning to a different phase is concerned. And speaking of phasing, phases, we'll move on to the next slide, starting naturally enough with phase 1, and that's where we are right now. And so because of that, I'm sure these facility requirements are going to be very familiar to all of us. Essentially, no visits, with the compassionate care exception, and Robin's going to speak more broadly about that. Entry only to the healthcare people who need to be there to provide services, social distancing within the facility, and then, as I mentioned, the level of testing that we just discussed. The next slide, please. The recommendations discuss how the facility has to be able to deal with residents who may test positive, that all of these phases, 1, 2, and 3, require that the facility have a space that could be dedicated for the care of residents who test positive, and a plan to deal with residents who in the future may be suspected of having a case of COVID-19. Then moving into phase 2 on the next slide, these are standards for the nursing facility to be entering phase 2. The local community, first of all, has moved into phase 2. There haven't been any new COVID cases in the nursing facility for 2 weeks. The facility has to be adequately staffed and equipped. And then there also has to be adequate hospital capacity in the region. Move on to the next slide. So those are, first, we just talked about the criteria for entering phase 2. Now we're talking about the standards, the rules, the procedures that the facility needs to be able to follow. It looks a lot like phase 1. So if you're looking at the difference, it's really relatively small difference moving from phase 1 to phase 2. Most importantly, you'll still have a similar limitation on visitation. It'll be just as limited. Essentially, the only 2 recognizable differences between phase 1 and phase 2 are these points listed here. There's a bit more room for the facility to allow entry of so-called non-essential healthcare personnel, not completely open admission of such persons, but the language is such that the entry is more open than it is in phase 1. And then secondly, there's a slightly greater ability to conduct group group activities. There's a specific mention of outings and a specific mention of a size of a group, 10 or fewer persons. That's phase 2. Moving on to phase 3, and the next slide. Here again, the community surrounding the nursing facility has to have moved into that phase. And then within the nursing facility itself, the facility must not have had a new COVID case in the facility for essentially the preceding month. Again, the facility has to be adequately staffed and equipped, and the local hospital capacity must be adequate. Now here, moving on to the facility standards, and the next slide, there is a recognizable difference. Now you have visitation allowed, but with, it's not going to look like visitation in January of this year, for example. It's still a COVID-19 world to a certain extent. And so because of that, social distancing is required along with use of masks and the kind of precautions that we're all familiar with at this point. There is allowable entry of the non-essential healthcare personnel. Volunteers are allowed to come into facilities, and there's a broader recognition of communal dining and activities with no particular limit on the group size, but with, again, the kind of precautions that I think a lot of us are familiar with in day-to-day life. And through, as is true through all of these phases, continued testing and screening. And screening, which I didn't discuss specifically before now, deals with, for example, taking staff temperatures and resident temperatures on a daily basis. Moving on to the next slide, just want to make a note about how CMS is considering a new case. A facility can have a COVID positive person in the facility without that being considered a disqualifying new case if that person entered from a hospital, entered from outside the facility. What prevents a facility from moving into the next phase would be a case that developed in the facility, which is indicative of transmission within the facility, but which is suggested in the document and which was articulated by CMS official yesterday. They are not in making those considerations, considering the admission of someone from the quote unquote outside. The fact that the facility has had some with a positive test coming from the hospital doesn't necessarily prevent the facility moving into the next phase, because that's not a case that arose evidently from transmission during the facility, within the facility itself. And then finally, moving on to the final slide, the crosswalk that I've been summarizing here about phase 1, phase 2, and phase 3 also talks about surveying procedures during those 3 phases. And this is the quick summary of that. Phase 1 is, again, we're in phase 1 right now, essentially. And so it's very limited survey activities, limited to immediate jeopardy situations, these infection control surveys, initial certifications when the facility needs to get up off the ground and open, in addition to state priorities, to the extent the state survey agency chooses to focus surveyor activity in one way or another. Phase 2, relatively similar to phase 1, again, very limited, but with the addition of the surveyors looking into complaints that were alleging actual harm. And then phase 3, relatively normal survey operations. The surveyors will once again be looking at complaints, for example, without the triaging of determining whether those complaints are alleging immediate jeopardy or actual harm. So with that, I'm going to turn the microphone over to Robin to talk about some advocacy ideas.
Thank you so much, Eric. Because it appears that CMS is in large part deferring a great deal to the states for the reopening. I want to highlight a few advocacy tips that we would encourage those of you who are advocating at the state level to pursue. Next slide, please. So first, the CMS recommendations encourage state leaders to collaborate with the state survey agency and state and local health departments to decide how to relax restrictions using a phased approach. So that means it's really important that state leaders hear the perspective, I think, of advocates when considering how and when nursing homes will be reopened. So we urge you to advocate for the involvement of the Long-Term Care Ombudsman Program and citizen advocacy groups in that decision-making process. A second recommendation is relates to state survey agencies and the survey activities. Eric laid out for you and what CMS is recommending related to what surveys to do when, but there's also under each phase a part that says states can do surveys based on their priorities. So they're permitted to perform surveys during any phase based on their own priorities. So since right now there are basically no eyes seeing what's happening inside nursing homes right now, getting surveyors into facilities as soon as possible is, we think, is really critical. So find out what, if anything, your state survey agency has prioritized. So for instance, maybe it's prioritized going in to facilities with a high number of COVID cases. That's just an example. Or maybe it hasn't prioritized anything. So in that case, advocate for the state survey agency to set its own priorities for surveys and advocate to participate in developing the criteria for what you think should trigger that kind of on-site survey. And if the state is conducting some surveys, at least based on its own criteria, then determine whether you think that criteria focus on the right priorities and then advocate accordingly. So this next advocacy recommendation has to do with visitation, which we know is just such a huge issue. As you all know, right now, visitors can only be permitted under what CMS calls compassionate care situations. So we, like you, are hearing that the isolation that residents have been experiencing for now more than 2 months at this point is really harming residents, and that residents whose family had been the ones to help them eat, drink, sit up, communicate what they need, and so on, are really suffering both physically and emotionally. So for that reason, and we think as a first step in this phased approach to the relaxation of restrictions, we think that the way compassionate care situations are interpreted could be expanded. And we're suggesting that advocates work with the state to try to get a definition of compassionate care situations that might extend to family who provide some of these essential physical and in many cases psychosocial support to a resident that is really life-sustaining. It's not an easy definition at all to come up with, since it absolutely needs to be balanced with preventing the transmission of the virus. But one approach that we suggest is that a group of state stakeholders should be convened. Stakeholder group should include the Long-Term Care Ombudsman programs, citizen advocacy groups, residents and families, as well as others, to talk about and try to define the interpretation and the circumstances under which families in this very limited way could be permitted to come in. So let's see, next slide, please. Okay. Another advocacy recommendation is to continue to support adequate PPE and testing. This has been one of our recommendations for quite some time now. I'm sure you really know very well by now why PPE and testing are so essential. You probably heard it many, many, many times, so I'm not going to go into those reasons. But what I do want to note is that adequate PPE and testing are now also critical because they've been identified by CMS as factors that need to be considered in relaxing any restrictions in nursing homes. So both PPE and testing are really essential to limit exposure to the virus and need to be in place before additional people are permitted to enter a facility. So we urge you to continue to advocate for both those items. The fifth and last advocacy recommendation, these are just very, a very short list of advocacy tips, but we're recommending, and this is something that we have been already recommending, but it's really critical to require daily facility reporting and state monitoring of at least the items that you can see on the slide. The number of cases, the number of fatalities, and that should be both COVID related and non-COVID related, staffing levels, and the available supply of PPE and testing kits. So this should not be burdensome for facilities since we know they're tracking this data already and they're reporting almost all of that to CDC at least weekly. Now this recommendation goes a step farther because it calls for daily reporting. And the reason for that is because we know that the virus can spread so quickly that the number of cases and deaths can really, can change really rapidly. And it also calls for daily monitoring at the state level so that the number of cases in the community and in each nursing home can be closely tracked, and the state can make adjustments to its plans for reopening. And those adjustments may need to be made very quickly if necessary, and that's why daily reporting and daily monitoring are really essential. So I just want to end by noting that the one thing that appears clear is that a lot of reopening and relaxing of restrictions is going to play out at the state level. So we just urge you all to advocate, to participate in and help shape that process so it accomplishes its ultimate goal, which is to contain the virus and prevent it from continuing to spread while permitting residents to reconnect with family and others in their lives who are so important and essential to them. So with that, I'm going to turn things over to Toby.
Thank you, Robin. I want to spend a few minutes talking about a new GAO report on infection control. Next slide, please. The title of this report, which just came out this past Wednesday, 2 days ago, is Infection Control Deficiencies Were Widespread and Persistent in Nursing Homes Prior to COVID-19 Pandemic. And that title just about sums up what the GAO found and how significant this problem is. Next slide, please. The GAO looked at two sets of data from 2013 to 2017 and then 2018 to 2019. A new survey process, as we know, went into effect November 2017 with new codes. So the GAO did not look at the data from that brief period of time from November 28th, 2017 to December 2017. Next slide, please. This is what they found. 82% of nursing homes in the country were cited with one or more infection control deficiencies in that 5-year period. 48% of the facilities, so nearly half the facilities, had infection control deficiencies in multiple consecutive years. 19% of facilities had multiple infection control deficiencies, but in non-consecutive years, so 2013 and then maybe 2015 again. 35% of facilities had infection control deficiencies in 3 or 4 consecutive years, and then 6% were deficient all 5 years. All 5 years they had infection control deficiencies. Next slide, please. In each of the reporting or the data periods that the GAO looked at is about the same proportion of facilities that were cited with an infection control deficiency in each year. From 2013 to 2017, it was between 39 and 41% of facilities. In the 2018-2019 time period, it was 40% of facilities. So that's about the same percentage all the time. Next slide, please. What the GAO also said is that 99% of these deficiencies were cited as no harm. And so as a result of being called no harm, 67% never had any kind of penalty imposed or implemented, and 31% had a penalty imposed but not implemented because they were given an opportunity to correct, and they corrected the non-compliance before the penalty went into effect. Now, we know that there are 4 levels of harm in the federal enforcement system. The top 2 are immediate jeopardy and actual harm, and they constitute about 4% of deficiencies. But here and then the bottom 2 are no actual harm and substantial compliance. What the GAO found is that even more than other kinds of deficiencies, infection control was called no harm, was even 3 or 4% considered harm or jeopardy. Almost everything was called no harm. And so the GAO found that there had been any kind of financial penalty imposed only against 1% of the facilities for their infection control deficiencies. Next slide, please. The GAO also looked at which facilities were more likely to have infection control deficiencies. Now, for-profit facilities fared more poorly on the infection control measure. For-profit facilities constitute 68% of facilities in these 2 time periods, but they accounted for 72% of infection control deficiencies that were cited, and only 61% of facilities that never had an infection control deficiency. So they fared more poorly on having infection control deficiencies and on being deficiency-free in infection control. Next slide, please. The other factor that GAO looked at was overall ratings of 5 stars on the 5-star quality rating system on Nursing Home Compare. So of course, 5 stars is the top rating. 17% of all facilities have a 5-star rating. These facilities were less likely to be cited with infection control deficiencies. They accounted for 33% of facilities not cited for infection control deficiencies, and only 10% of facilities that did have an infection control deficiency in multiple years. So higher performing facilities did better, had fewer infection control deficiencies. Next slide, please. The end of the report, the GAO includes a lot of state-specific data, so you can go look and see how your state performed. They looked at the number of surveys, the report, the number of facilities with an infection control deficiency, and then by state as well, the number of facilities that had an infection control deficiency in 1 year, multiple consecutive years, and multiple non-consecutive years. So there's a lot of information, state-specific, at the back of the report. Next slide, please. What GAO says is that it plans to examine the CMS guidance and oversight in infection prevention and control in a future GAO report, including the classification of infection prevention and control deficiencies. That's where that language is included, is in the highlights, and that's something that we should be trying to participate with and contribute to, because GAO is not done with its work in infection prevention and control. Next slide, please. So that's where I am, just in case you need to find me. These GAO findings, I just want to say in conclusion, are very important to counter the nursing home industry and its apologists. They are arguing now that COVID-19 is correlated with zip code, who lives in nursing homes and where facilities are located, not on the quality of care provided by facilities or low staffing or prior infection control deficiencies. The industry is making a concerted effort to change the narrative from their own bad practices that contributed to the spread of COVID-19 to blaming the residents. And we'll be pursuing this issue in the days and weeks ahead. Now I want to turn this over to Richard. Thank you.
Toby, thanks so much. I'm Richard Mollett with the Long-Term Care Community Coalition, and I'm going to be, as Lori had mentioned, reviewing some of the federal reporting requirements, both for families and for residents, as well as what facilities have to report to the federal government. Next slide, please. So first, in regard to reporting to residents and families. And again, this rule went into effect just about a week ago on May 8th, and facilities do have some time to come into compliance with it, although I would say the time that CMS is giving them is really in respect to the reporting to the CDC, not in respect to reporting to residents and families. So this, what I'm going to talk about on this slide, should be happening right now. Pardon me. So nursing homes, they need to inform residents and the residents' family members, their representative, et cetera, of those residing in the facility by 5 p.m. the next calendar day following the occurrence of one of the following, a single confirmed infection of COVID-19 in the facility, or 3 or more residents or staff with new onset of respiratory symptoms occurring within 72 hours of each other. Pardon me. That's really important. Just to note here, we've already gotten some questions about this. This rule is prospective, meaning that CMS issued it on the 1st. It went into effect on, as I mentioned before, on the 8th. It does not go back in time. So the facilities don't have to report previous infection control, previous COVID-19 infections or suspected infections. They need to only report from May 8th on. There are a variety of ways in which facilities can meet this requirement according to the federal government. They can do that through email listservs, through website postings, through paper notification, and or through recorded telephone messages, one of those robocalls. I personally don't like those. I think it's a little bit difficult for people to hear about what's going on with their loved ones from a robocall, but we do want people to be aware that nursing homes are allowed to do that. It is permissible, and that's what they may be receiving. CMS also notes that they don't expect facilities to be making individual calls or sending individual letters to residents or to residents' families. So people who don't have access to the internet or don't check their phone, they really need to be careful and to be thinking about this, because they may find themselves to be out of the loop if the facility is reporting in a certain way and they are not, they're not connected with that. So just something also that we've heard from families who may not be using the internet, et cetera, and then don't feel like they're getting the information that they need. That's, as I'm saying here, that's what CMS has said facilities can do. And so we need to just be thinking about that. And I would recommend, if you're not hearing something, if you don't know where to get information, contacting your local ombudsman or your family council, which can be a great source of information and advocacy. Next slide, please. Excuse me. So in respect to reporting to residents and families in the following, I'm just going to read it through because I think it's important language, which I paraphrased from the CMS rule. This information cannot include any personally identifiable information about particular residents who, again, are either COVID positive or have respiratory issues. It must include information on mitigating actions implemented to prevent or reduce the risk of transmission, including if normal operations of the facilities will be altered in some way as a result. It must include any cumulative updates for residents and their representatives and families at least weekly, or by 5 p.m. the next calendar day following the subsequent occurrence, again, of either a confirmed infection of COVID-19 identified in the facility, or 3 or more residents or staff with new onset of respiratory symptoms within 72 hours of each other. So again, and I just want to reiterate, as I mentioned earlier, the cumulative updates start on May 8th. And I know that people will reasonably be frustrated by that, because of course we want to know, have a good idea what's going on in our facilities and what went on in our facilities in March and in April and in the first week of May. But CMS has made clear to us that this is, again, forward thinking. It doesn't require facilities to report backwards. That being said, I would, certainly, even though it's not part of the requirement, I would certainly recommend, requesting the facility to do that or to provide that information. There's no reason why they couldn't voluntarily. Next slide, please. I want to talk a little bit about what the nursing homes will be reporting to CDC, and in turn, what information that will be provided, to the public about nursing homes. As I'm sure everyone knows, there's been a lot of confusion, a lot of unevenness between nursing homes and between the states as to what is reported and what isn't reported, whether it's deaths, suspicious deaths, whether it's suspicious cases or known cases of COVID-19, that there is a large variety. So this really lays down a minimum of what has to be reported by the nursing homes. Now, just to be clear, because sometimes this gets confusing, the Centers for Medicare and Medicaid Services, CMS, they're the ones who develop these rules and other rules for nursing homes, and they're the ones who are ultimately responsible for ensuring that the state agencies, the departments of health, et cetera, are ensuring that these things are implemented in on a facility basis, and of course that care standards are met, and they're responsible, of course, directly for paying and overseeing care in nursing homes as well. It's the CDC, the Centers for Disease Control and Prevention, which has come up with a variety of recommendations, both generally and in particular to facilities over the past couple of months, and guidelines. But those guidelines, just in terms of infection control and prevention, are not the same as guidance, and the rules which we're talking about today, which come again from CMS. So I know it can be confusing, and I hope that provides just a little bit of clarity. So here, what we're talking about, this is the federal rule that came out again at the beginning of May, and it comes from CMS, but CMS is requiring that the facilities report this to the CDC. So they must report suspected and confirmed COVID-19 infections among residents and staff, including residents previously treated for COVID-19. They must report the total deaths and COVID-related deaths among residents and staff. We think that's critically important. They must report the personal protective equipment and hand hygiene supplies that they have in the facility, their ventilator capacity and supplies in the facility, their number of resident beds and the resident census. So again, their capacity in terms of resident beds, as well as the actual census, the number of residents in the facility. They must report access to COVID-19 testing while a resident is in the facility, any staffing shortages, and other information specified by the secretary. Secretary being the head of the Department of Health and Human Services, which oversees CMS. Next slide, please. This information, in turn, well, one, it's going to be reported weekly to the CDC, Centers for Disease Control and Prevention. And you can see in quotes here in the second bullet, this information will be posted publicly by CMS to support protecting the health and safety of residents, personnel, and the general public. It'll be posted by CMS on their website, data.cms.gov. And we all, our organizations, will be monitoring this and will report back in future programs, as well as via, we all have newsletters and stuff. I know I read the other groups' newsletters, and so we're all tracking this and trying to make everyone as aware as possible. A few notes before I move on. When I first reported on this a couple of weeks ago for this program, we weren't sure what information was going to be reported by CMS to the public through this data.cms.gov website. We were told this week that CMS is expecting to publish all of the information that I mentioned earlier that is required to be reported to the CDC, that they will be providing all of that information to the public. The other quick point I wanted to make is that I saw there were a number of questions that came up before I got on about who's going to decide, who decides what insufficient staffing or staffing issue is. And that frankly will be, I'm assuming, decided by the facility itself. And it is something that we all, our organizations have spoken to both CMS and others in the federal government, including the Department of Justice, about, that we're concerned that facilities don't normally do a good job of identifying what staffing is sufficient, whether or not they have a staffing problem, and to leave that up to the facilities to decide here, or to alert us if they identify a need, is extremely problematic and not particularly useful, frankly. And we all, I forgot who mentioned this earlier on, it might have been Robin, we've all been advocating for, yes, it was Robin, for actual, reporting of actual staffing in the facility. That's been required for quite some time. If those of you who have gone into a facility, that nursing homes have to report the staff on duty. So we have simply been calling for that reporting to be done outside of the facility, especially now that we can't get in. Next slide, please. I just wanted to quickly mention a couple of the resources that we are putting up. We just updated this week our coronavirus page at nursinghomes411.org/coronavirus. So we're tracking the federal guidance and putting that up. We're also tracking some data, which I'll mention quickly on the next slide, news and reports and resources. And we connect back to, to our colleagues at the Consumer Voice in particular, for the different resources that they are providing as well, which are really excellent. Next slide, please. I just wanted to quickly talk about some of the data that we have published. So in our state, our home state is New York, they are just publishing the fatalities, but we've been putting that into searchable pages, Excel files, excuse me, so people can actually see where the fatalities are and track them better. If someone needed technical assistance and wanted help doing that in their state, send us an email, feedback@ltccc.org. We'd certainly be happy to try and help. There are national data on this as well that we link to through Kaiser Health Foundation. I just wanted to quickly mention, we just published this morning, the latest nursing home staffing data from the 2019 fourth quarter. This just came out about 2 weeks ago on the underlying database at CMS. And those of you who might be familiar with our work, we put those into searchable state files. And I think it's particularly useful just to get a sense of, as Robin was mentioning before, how are we going to be looking into what kind of recommendations should we be making on a state level for what the state agencies should be doing, the departments of health, when they go into nursing homes. And one way would be, of course, to look at the previous staffing data, to look at in the provider information we actually provide, ratings, citations, or overall fines, et cetera, for every facility in the country. And then with the infection control citations, as Toby was saying, I think another critical insight into nursing homes that have had serious problems in the past. Next slide, please. And that's it for me. Our website again is nursinghomes411.org, and thank you very much. I think I'm the last person speaking.
Yep. Thank you so much, Richard and Eric, Robin, and Toby. Thank you so much for your presentations and the valuable information that you shared with all of us this afternoon. We will turn to questions now. We have about 15 minutes left in the program, and a number of questions have been coming in, and Sam and Jocelyn are going to help us review those now. So why don't I turn it over to Sam and Jocelyn to queue up the first question.
Sure. There was a question about what in this, what encourages nursing homes to move into the different phases, if anything?
What encourages them to move into the different
The
phases?
different reopening phases. Say
Like,
from
what's their incentive to
yes, what's
improve
their
and
incentive?
move from one phase to the other? Well, certainly allowing reopening to allow additional services and families back in is definitely one. Anyone else want to add anything to that?
Well, this is Richard. I was just going to quickly say that I think a lot of it comes down to what the states are doing and how the states are moving forward, or the communities themselves are moving forward.
Yeah, it's not the facilities to decide what phase they're in. As my understanding, is this true, Eric, that it's determined by the state, and they have various ways, CMS sets out in its recommendations, various ways that state can do it, statewide, countywide, facility-wide, but it's the state's decision.
That's my understanding. This is Richard.
Yeah.
Well, no, but it's, it depends on the facility being free of new cases for X number of weeks, for example. So,
Yeah.
that's in staffing is obviously facility specific as well. If you look at the criteria, it talks about the nursing home having adequate supplies of PPE and enough disinfectant. The nursing home has adequate access to testing. And so there's some of its community. So I'm reading it as there's a threshold the community has to qualify. That is, this case status in community is at a certain level, and that the hospital capacity in the community is such a level. But some of the rest of these are facility specific.
That's true.
Okay, next question.
Sure. Someone had asked, and this is a really important point, what advocacy recommendations are there for facilitating ombudsman access into nursing homes, potentially in phase 2, if not sooner, but what recommendations do you have to get ombudsman in before all visitors?
So this is Robin. I'll just jump in. I think that a fair amount of the advocacy for ombudsman access needs to be targeted to CMS, frankly, because CMS are the ones that have included ombudsman as part of the visitors. And said that they have the same status as visitors. So I think putting pressure on CMS is probably the one of the ways to go.
I think it also, go ahead, Eric.
Go ahead. No, you first, Laurie, go ahead.
Well, I was going to say that I agree with Robin in terms of CMS. I think also working at the state level in terms of looking at what is appropriate and makes sense for allowing ombudsman visitation. They've not been accepted out specifically in any of the guidelines that have been included, both related to exceptions from the restrictions, nor in terms of where they fall in the list of visitors for reopening. So this is something that should get more clarity, and I also would suggest that as the states are looking at what their processes are for opening up facilities, looking at where the ombudsman program and adult protective services and protection and advocacy fall into that as well. Eric?
Yeah. I agree. 2 points. First of all, I just searched both those documents. The word ombudsman doesn't come up at all. So, and I think, for the purpose of advocacy, you don't have to assume that ombudsmen are just lumped in as visitors here. I know they've been in the same status more or less in previous guidance, but these documents don't say ombudsman, they just say visitation. So I wouldn't assume that that's that they absolutely have the same status as visitors, because it's not mentioned. And then secondly, of course, these are just recommendations. So CMS makes that clear. So there's nothing, there's nothing preventing you from going to the state and saying, look, these are just recommendations. And frankly, they don't say anything about ombudsman. And you make your case as to why the ombudsman is really important and should get in a little bit ahead of the mass, if you will, of family residents who because one Faith Street is everybody's in, and I think you can make a very strong argument that given the importance of the ombudsman program and their ability to follow the guidelines appropriately, and the big bang for the limited impact in the facility, a big positive bang, that under state guidelines they should be allowed in earlier.
Great, thanks, Eric. Next question.
There are a couple questions about reporting. One of, I think the broadest is, how do we make sure that there's no underreporting from facilities? But there are also a couple more technical questions about whether or not the information is going to be listed on the CDC website by individual facility or by state, and whether or not facilities are required to report if they have not had any confirmed COVID cases in the past week.
Well, they don't have to. Well, let me start from the beginning. Could you repeat the first question? I'm sorry.
Sure. The first question is how we can be sure that there won't be underreporting from facilities.
So, we unfortunately can't be sure that there won't be underreporting. As I mentioned when I was speaking before, this is something that we were actually just talking about with people at the Department of Justice today, and will certainly be, all of us, be advocating to make sure that there is integrity there. I would certainly reach out to your state auditor or state controller's office, as well as the Attorney General's office, to urge them to do an audit or to do an assessment of the reporting in the future. And if you're seeing, or if you know, for instance, that things are not being reported, of course, contacting your state agency, they're responsible for enforcing this. And, oftentimes it's at least as helpful to contact the long-term care ombudsman, and I would say even, a state legislator or congressional representative, to say, you're not getting the information that you have a right to get. Next part, please.
Can I just say something about that as well? I'm very concerned about underreporting unless we are testing all residents and all staff. The New England Journal of Medicine had a study, I think we've talked about this before, of the Seattle nursing home where COVID was first found. And they tested all the residents, and the majority of residents who tested positive were asymptomatic. Older people who have COVID-19 may not have high temperatures or coughs or respiratory symptoms. And if that's all we're looking for testing, and if we're not testing everybody, we could be missing a lot of residents. So I think we should really be encouraging 100% testing of residents and staff so that we get accurate information about who is COVID positive and not. Thank you.
Those are good points. Thanks, Toby. I could try to quickly go through the other questions if you could just repeat them.
Sure. The other two I think are a bit faster. Will the information published on the CDC website be listed by individual facility, or is it just going to be? Okay. And then facilities, are they required to report weekly cumulative updates when they have not had any cases in their facility?
Well, if they've not had any cases at all, then I guess they would probably say they have nothing to report and would not be held accountable for not reporting a nullity. I mean, I would hope that all facilities would report, just to maintain those lines of communication, especially given how, as we've all been saying, how disconnected families and ombudsmen are from what's going on in their facilities. So, but yeah, I guess, but if there's, even if there's not a new case, they should still be reporting, cumulatively, at least on a weekly basis.
So this is Robin. I wondered if I just wanted to tell folks that, what we're hearing is that, yes, the information about, number of cases, fatalities, and so on will be, in fact, on Nursing Home Compare. And we anticipate that it will definitely be by facility. We were very adamant that it does need to be listed by facilities so people, can get to the information quickly.
Mhm.
Now, when that exactly comes out, we're not 100% sure. CMS told us this week their target is the end of May, which of course is next week. So I guess we'll see.
Right. And as soon as we know, we'll let you know for sure on when it's available. Thank you. Next question.
One question was, when there are no cases in a nursing home, are residents able to play games socially or eat meals together using protective masks?
So I'm not 100% sure of the answer to this, and if any of the others of you know, please jump in, or even those of you who are on the call, if you have experience with how this is working in facilities that you're connected with, if you could let us know that as well. I have heard a couple situations of where there have been some limited interactions with social distancing going on in some areas of facilities if there are no confirmed cases in those areas. Again, if the protocols are for social distancing are being put into place and they're not bringing a lot of residents together at a particular time. But with respect to like congregate or group activities or things like that, I've not been hearing that has been happening. Any of the others of you?
Yeah, I think you're right as to it not being happening, but I'd point out that the CMS guidance, or recommendations rather, are maybe a little more receptive to that. Here's the language for phase 1. Restrict group activities, but some activities may be conducted for COVID negative or asymptomatic residents only, with social distancing, hand hygiene, and use of a cloth face covering or face mask. And then, as I mentioned, phase 2 is a little bit broader than that, talking about outings and up to 10 people. So, but even in phase 1, there's a recognition that if you have social distancing and precautions, you could conduct activities in the facility.
Mm-hmm.
And this is Robin. I would add to what Eric said that the same thing goes for communal dining. It talks about it being limited for COVID-19 negative or asymptomatic residents only, but it says residents may eat in the same room with social distancing, limited number of people at tables and spaced by at least 6 feet. So there's that as well. And I will actually add that in our conversation with someone at CMS yesterday, he was actually talking about seeing bingo being played in a nursing home, 6 feet apart. So, and that was happening already.
Mm-hmm. Thanks, Robin and Eric. I think we could do one more question.
There was a question about what happens if a facility doesn't want to reopen, if it doesn't want to, it likes not having visitors and doesn't want to go through the phases to reopen.
Anyone want to start with that one? We can probably talk about that all day.
Oh, I'll just say that I think it's unlikely that,
Mm-hmm.
I mean, who wants to be the facility in town that has no visitors whatsoever? I can't imagine that makes sense. I don't run a long-term care facility, but I would think that would be death from a marketing perspective. So I know that we've talked about the fewer prying eyes and the lesser survey levels, but I don't consider, I can't imagine that's a viable business model.
Mm-hmm. And I would also think that if that were the case in a particular facility, that they were lagging much farther behind other facilities in terms of opening up, that's actually going to draw a spotlight to them in terms of needing to have the surveyors really look at what is happening there that's causing them to lag so far behind. What are the challenges that place is having, and what kind of additional supports, so to speak, might be necessary to push them along into the direction to get to the place where they are able to reopen. So, okay, I think we are at the top of the hour, and we're going to need to close for today. Thank you again to all of you for joining us, and to Eric, Robin, Toby, and Richard for your presentations and help in answering the questions today. Thanks to Jocelyn and Sam and Libby for helping with questions and behind the scenes. We will be doing this again next week, so please join us. And we are again reviewing all of the questions and chats that you send in. We've been updating our frequently asked questions on the Consumer Voice website. I think a new set are being put up as we speak, and continue to watch our websites and your emails for additional information about what's going on from all of our organizations. Thanks so much for your time today, and we'll talk to you next week. With that, we'll close for the day.